Clinical problem solvers.
Woo!
Welcome to another RLR Friday edition. Hope you all are having a lovely day. And good morning, good afternoon, good evening. Robbie, how are you?
I'm doing very well. I see a face I haven't seen in a while. Varun is here. You see that, Prof. Fred?
Oh,
Hi,
the last
Varun.
time when was the last time we saw Varun? Under what context was it?
It was about, we were in the lovely city of Austin, Texas at a conference where there were 4 people. 2 of them had a complete professional attire and the other 2 were half naked. And that's the context that we saw Varun. Before you all get any dirty ideas, no, we were at the pool. Prof. Rez and I were hanging out at the pool, and we're joined by Varun and some other people. I don't know if you know them, but some other really wonderful people. Hi, Varun.
Hey, Varun, how was that shrimp that I gave you by the pool?
It was great. Thanks, Rez. Good to see you guys.
The guy just met us. I was like, hey, have a shrimp. Robbie was doing laps in the pool. Well, I think it's a time where we ask for a case presenter. If there's anyone that would like to present a case, we would welcome that. I'm going to take out my Invisalign so I can have some coffee while you guys are going to volunteer a case. Robbie, any luck?
Looks like there's some people coming to the rescue, but nothing concrete yet. Shema has something as a backup, but would prefer to wait to see if anybody has a fresh case.
This Sunday, Robbie, I have some great Sunday or Saturday. I have some great cases for you.
Oh yeah.
Oh my God! Like
From
really.
what context?
Oh wow! It's gonna be because I was just on service.
Yeah.
And I was looking at my list. I like took care of like 40, 50 patients during the 2-week span.
Wow.
But I'm gonna have 3 patients that I'm gonna present to you in one episode.
Oh no! Amazing. Alrighty. 3 in 1 go, huh?
Yes, sir.
Alrighty. I look forward to it. Shema, what do you think? Shall we do it?
Can you all hear me?
Yeah, you sound great.
Okay, sorry. So then I would start with the first aliquot. So we have a 57-year-old female that is presenting with severe muscle weakness, fatigue, and weight loss for the past 2 years. And I would stop here.
Oh my gosh. Wow. What an emphatic start, Shema. Thank you. Yeah, Prof. Rez, maybe I can just reflect big picture about the muscle weakness and then pass the mic to you to share the other things in this space. And I think that the words muscle weakness are a little bit tricky. And I think when your patient comes in and presents a localization to you, you should probably trust and verify. I think there's a tremendous amount of very helpful information here, but I think the thing to not lock in on is to assume that the source of the weakness is muscular in nature. In fact, I'd make the argument that you probably shouldn't even assume the patient is neurologically weak, and they may be simply referring to the fact that they have myalgias. So you can see that these words can put you down a tunnel where you can make the assumption that the patient will have muscle weakness, but they may not have weakness. They might have myalgias, or they may have weakness, but it's not in a muscular distribution and have a non-muscular cause of weakness. So a lot of caveats here. But I think what do these words usually signify? These signify the probability that the patient has a pain syndrome. So I'm much more likely to be confident that a part of this patient's body hurts, and that part is probably the extremity. So the only thing that I know for sure, pending more HPI about the functional implications of this muscle weakness, if she follows this up by saying, hey, I can't pick things up, I can't get out of a chair, so on and so forth, then it's much more likely to be weakness. But so far, I think the only thing that I can be confident about is that this patient is hurting in her extremities. And the questions are, is she neurologically weak? And if that neurological weakness is at fall in a myopathic pattern. So that's my piece of advice about the muscle weakness. But the good news is that's not the only data we have so far. So I'll pass the mic to Prof. Rez to pontificate about this and anything else you want.
That's awesome. And Shema, you said there was also weight loss, correct?
Exactly.
Okay, perfect. So it's so interesting. Robbie, I loved your approach on the muscle weakness and not prematurely closing on a neurologic problem. With the fatigue, I put that to the side. Fatigue is such a non-specific symptom, and we all experience it. It's like one of those symptoms that can be caused by a million things, so you don't want to invest any cognitive energy there. What really is interesting is this weight loss. But even with the weight loss, you have to be cautious here because, one, you need to verify that there was weight loss. You want to categorize the severity of weight loss. Was it just a couple pounds? Or was it 40 pounds over 4 months? The morning report was 40 pounds over 4 months. So that's real weight loss. And then was it intentional or not? Now, what's so interesting about medicine is that it's nothing like a textbook where there's right and wrong. Meaning someone could say they're having intentional weight loss, but it's so severe that you just can't trust that it was all intentional in nature. And so I think what would really help, and I'm not going to share a schema for weight loss just yet, because I think it would be a waste of cognitive energy, is to try to understand how severe the weight loss was by looking at prior weights. If there aren't prior weights, then the physical exam, looking for muscle wasting and such, will allow you to then say, hey, this weight loss is real. The weakness is real on an exam. Now, how can we connect these two together?
Amazing discussion. So I would now give you some more information. So to her medical history, she had a well-controlled migraine and depression that was being treated with somatriptan and citalopram. She also had chronic hypokalemia that was leading to multiple visits to the ED for muscle weakness. These episodes were treated with potassium, but only transient improvement. And to her health-related behavior, she denied smoking, drinking alcohol, or using recreational drugs. And on further questioning, she was complaining about dry eyes and dry mouth for the past 5 months. And as I already mentioned, she had weight loss that was unintentional of 8 pounds during the same time. And I would stop here before giving more information.
So here a pattern has emerged. But before we talk about that pattern, maybe what I can do is I can talk about the potassium and then leave the Sika-like symptoms for Robbie to dissect and see how it might explain this patient's presentation. But you know, Shema is so interesting in medicine. Like, it's easy to identify an abnormality because the lab will tell you, the imaging will tell you, hey, the potassium is low, the patient has iron deficiency, the patient's hyponatremic. But what the lab doesn't tell you is why. So all of this is referred to as a proximal diagnosis, meaning a proximal to the ultimate end diagnosis. With potassium, it can certainly, if you think about it, potassium is so important for neuroelectrical activity and muscle contraction. And so if the potassium is low, it can affect the heart, the GI tract, and the muscles. But in order for potassium to affect the muscles, like, you really have to be sub 3, like sub 3. And I would even say maybe even lower than that. So it's really important to sort of see on prior visits, because this patient has been to the ED multiple times, how low was that potassium? But let's go ahead and share a quick approach to hypokalemia. And when you're treating By the way, I had to make sure I'm talking about hypokalemia because sometimes the problem will be hyper K, and then Robbie will listen to me speak for 5 minutes, and then I'll look like an idiot. But anyways, this is hypokalemia. And with any kind of electrolyte abnormality, the question becomes, is there decreased oral intake, which is almost never the right answer? Is there increased GI loss, which could be the right answer? Is there increased renal loss, or is there transcellular shift? So base rate approach to hypokalemia is the patient vomiting? Are they having diarrhea? Are they on a diuretic? This will probably capture 90+% of hypokalemia. And we still haven't answered, is that actually causing the muscle weakness? Because we don't know the severity of the hypokalemia. It's kind of obvious when a patient's having diarrhea, but not always. So I don't think that's going on here. There's no mention of vomiting. There's no mention of diuretics. So then you're really perplexed by what's causing this. And this is where a pH would be really helpful, because now you're starting to think about either stuff like transcellular shift or stuff like renal loss that doesn't necessarily affect the pH. So I will leave it at that. And I would ask Robbie to comment on the dry eyes and if we can link that to any other part of the story. And then the depression can lead to weight loss if someone's depression is not well managed. So you have to keep that in mind as well.
Yeah, no, I love that, Professor. I think that's so powerful how hypokalemia can be helpful, but I think the caveat that it may not be severe enough to explain everything is such a wise one. And the truth is, I'll just be realistic with you. There's no way that I would have ever gotten this information at this time. The reason for that is, so far, I think that unless we build a case for some specific, if we go down a specific tunnel, which we need 2 or 3 more data points, I would never ask this question. And so the real value in studying it now is to recognize and ask the question, how many of you here, 22 people, have had dry eyes and dry mouth? And I would bet it's nearly 100%. So, but only Prof. Rez is willing to acknowledge it publicly. Thank you, Prof. Rez. I appreciate it. I think it's such a common finding, which is why the diagnosis that we've been reflexively programmed to think of from first aid, step 1, step 2, and step 3 is Sjogren's syndrome. But Sjogren's syndrome, you need 4 other criteria to make the diagnosis. You need to prove that there is objective dry eyes and dry mouth. You need to have antibodies, and you need biopsy, and some total of those things. So dry eye and dry mouth are very, very common findings that may be true and unrelated. So here at this point in the case, if you're putting your diagnostic clinical reasoning VMR hat, you would make value of it. But in real life, you would probably ignore it. And so I think we should probably ignore it for now until we build a bigger case and see if it's related. In the meantime, I've gotten some dry mouth now, so I'll pass the mic to Shema so I can fix that problem.
Superb discussion. So now giving you something about her physical examination. So her vital signs were within normal limits. She was cachectic with marked temporal wasting, dry mouth, poor dentition. There was no thrush. Her cardiopulmonary exam was unremarkable, and there was no organomegaly palpated. Her neuro exam revealed decreased muscle strength in upper and lower extremities, both proximally and distally. And her tendon reflexes were decreased throughout, but her sensory and vibratory function were intact. And now also giving you some labs, some first labs. So her chloride was 122. The bicarb was 16, potassium was 2.5. Her serum creatinine was 1.3 with an estimated GFR of 42 milliliters. And her blood urea nitrogen was 16. The remaining electrolytes, including calcium, magnesium, phosphorus, were normal. Her arterial blood gas analysis was showing a pH of 7.29. Her the partial pressure carbon dioxide was 26. Partial pressure of oxygen was 134. And before giving more labs, I would stop here.
Really, really interesting story, Shema. Thank you. I'll just tackle the exam and leave the labs to Prof. Rez. And I think the exam is very concerning because you're seeing that this 2-year disease has really taken a toll on its patient with the cachexia. And I think the other thing of significance outside the neurological dimension is the fact that she has poor dentition, because that's the one thing that makes you pay more attention to dry mouth. Because many people who have benign non-pathological causes of dry mouth will not have such profound continuous dryness that the absence of the enzymes in the saliva that protect us and help us maintain normal dentition are inconsequential. But in patients with pathological causes of dry mouth, the lack of lysozyme and other enzymes that protect against bacteria will accumulate dental issues. So now, both the labs and the exam tell you that this dry mouth is now of significance, and you probably in real life wouldn't have asked until this point. And I think the real practice from this VMR case is to see the pattern of poor dentition and maybe some other clues to then say, hey, do you have a dry mouth? But then the most interesting thing I would say is the neurological exam. And there are two things to study. The first is the patient has proximal predominant weakness. And also in parallel, the patient has reduced tendon reflexes. So this is actually going to be a really important conversation because they're immediately at odds. They don't add up. Proximal predominant weakness is a strong suggestion for a muscle issue, a myopathy. However, a commonly absent feature of myopathy is preservation of reflexes. So if you're running towards myopathy because of the proximal pattern, you should slow down a bit and take it down a notch by saying, wait, the reflexes are impaired. A reflex impairment is more consistent with a peripheral nervous system issue outside the muscle, such as a nerve issue, a root issue, an anterior horn issue, or even a neuromuscular junction issue. So to summarize, proximal weakness equals muscle, but reduction of reflexes is inconsistent with that. So how do we move forward with that? How do we move forward with this notion? Well, then we have to ask ourselves, is there a DDX for proximal weakness? And the answer is yes. There are a variety of nerve diseases that can be proximal in nature, but most importantly, the most powerful mimicker of a proximal pattern weakness is neuromuscular junction issues, including myasthenia gravis and Lambert-Eaton. Lambert-Eaton is an important mimicker to consider in this patient in large part because it is also accompanied by hyporeflexia, a feature that is not part of myasthenia gravis. So if you see this pattern of proximal predominant weakness with hyporeflexia in a patient who has cancer, that should cachexia, excuse me, that should evoke the possibility, could she have cancer and paraneoplastic Lambert-Eaton? So that's one possibility. However, it's much more likely that she has severe advanced muscle disease, so profound that she has lost her reflexes. So when can you get muscle disease? When can you get loss of reflexes with muscle disease? When the myopathy is so severe that it can no longer even trigger the contraction required for a reflex. And here, the rest of the laboratory signature is much more in keeping with a muscle issue, supporting that as your working hypothesis. So that's how I'd interpret the exam. The proximal weakness has a DDX. It's usually muscle. The usually is tempered by the lack of reflexes, which evokes Lambert-Eaton, but base rate and the subsequent data reinforce the idea this is a muscle issue. But I'll pass the mic to Prof. Rez to take us deeper into that data.
That I absolutely love that, Robbie. And I think that's like the beauty of medicine and the evolution of our thinking is learning those subtleties of like, hey, in order to have a reflex, you actually have to have muscle mass. If you don't have muscle, how are you going to have a reflex? And those things you learn by coming to VMR or experiencing it in real life. When you look at all this laboratory data, the most striking abnormality is the hypokalemia. This potassium of 2.5 isn't something that you just sort of replenish and don't ask, why is it happening? In fact, you need to get an EKG in this patient. You need to see their QTC. This is a patient that you would put on telemetry because they're at risk of torsades de pointes or a fatal arrhythmia. Okay, but before we talk about the hypo-K, I just want to briefly talk about the acid-base disorder in this patient because it's really fascinating. And when you're approaching acid-base disorders, I know it can be intimidating, but you just take it one step at a time. So what you need to recognize is that you need a bicarb and a VBG to accurately interpret the acid-base status. You cannot just look at this patient's bicarb and say, hey, this patient is having a metabolic acidosis, because the kidney might be compensating for a respiratory process. There is one acid-base condition that you can diagnose. Thank you, Jazz. I am practicing in French. One acid-base condition that you can diagnose just based on the BMP. Does anyone know what that is? Without a VBG, without a pH, you can diagnose this acid-base disorder. Put it in the chat. So there's only one, and see which one that is. But generally, you need both. So now we have the VBG and we have the BMP. So we look at the VBG, the pH is low. So we know we're dealing with acidemia, like this is an acid state. So then the next question naturally becomes, is it respiratory or is it metabolic? Does that make sense to everyone? So you look at the PCO2. If this was respiratory, you would expect the PCO2 to be high. So the fact that the PCO2 is not high, you know the primary disturbance is metabolic in nature. So we have metabolic acidosis. That's the primary process. So the next question becomes, is it an anion gap or not? And here, Shema was kind enough to calculate, to tell us that this is a normal gap acidosis. So it's not an anion gap acidosis. So we have a normal gap acidosis, but remember, that's just a proximal diagnosis. The question is, what leads to normal gap acidosis? We'll comment on that once we finish the acid-base disorder. Whenever you diagnose an acidosis, you need to use Winter's formula, a metabolic acidosis. So and this is to determine if the respiratory tract is doing what it should be doing. So 1.5 times 16 is equal to 24, is that right? And then you add 8 to that. 24 plus 8 is equal to 32 plus minus 2. So you expect this patient to be around that 32 mark. So this patient's actually blowing off even more. So there might be a component of respiratory alkalosis, meaning they're overdriving or overcompensating. But if we back up for a second here and ask the question, what is the acid-base disorder that you can diagnose based on the BMP? It's an anion gap acidosis. So now you have a normal gap acidosis, and that becomes a primary metabolic disturbance. The next test, actually, and here you can use the potassium, but before you even use the potassium, just so you know, the next step is actually measuring a urine anion gap, because there's really 3 buckets you have to think about for the normal gap metabolic acidosis. And that has to do with the GI tract, saline administration, or renal loss. And when the urine anion gap is negative, let me write that in the chat for you guys so you guys can see this. Now, this is just oh, thank you so much, Austin. Then you know you're dealing with a GI loss, a bowel loss. But this patient, we may send those labs, and I would probably send them, but this patient doesn't really have a history of any bowel issues, and they're not in the hospital getting saline. And so now we can use the potassium to help us. This is a big challenge. It's very hard to diagnose an RTA, because that's really what we're all considering here in the context of renal insufficiency, because early AKI and stage 3 CKD can cause an RTA. So you see how challenging it is. So in the setting, but then you use common sense. You're like, well, if this is renal injury, why is the K low? That doesn't make sense. with renal insufficiency, you expect the K to be high. So to summarize here, we have a patient who has a primary normal gap metabolic acidosis with no diarrhea, who has an either AKI or stage 3 CKD, but has significant hypokalemia. And Ravi put this in the chat, and this is actually an interesting story. Ravi, I was working with Dr. Glick. Is that the nephrologist? How do you pronounce his name? I want to make sure I do it justice.
I'm not 100% sure either, to be honest with you, but I think it's Stephen Glick, right? Or
The reason I'm mentioning this is you guys, he's a scientist, MD, PhD. And what he showed was that patients with Sjogrens he showed this through a case report, and you guys can Google his name, but they have antibodies. Those antibodies that target the salivary gland also target a portion of the nephron that causes the distal RTA in the context of Sjogren. So it's through, I wouldn't say molecular mimicry, but antibodies that are targeting both salivary gland and the nephron. It's like the same antibody, and there's same binding sites or whatever. And he showed this through a case report on patients with Sjogren and distal RTAs. And then that became scientifically known. And I got to work with this individual at UCSF. My mind was blown. It was in the context of a patient with hypokalemic periodic paralysis, very similar to this patient. So all this data, Shema, is very like, this is Sjogren's with distal RTA until proven otherwise. How something so rare becomes the most likely diagnosis until proven otherwise. Leah, which one do you want us to explain? I'm going off track here, Robbie. I'm reading the chat, I'm talking.
Oh, from what I can tell, I think Leo is asking Mingyu her cheat sheet for correction for Winter's formula. I don't think it was something you were discussing, it's just a conversation in the chat. You know, I think there's just so much wisdom here, and I can't wait to hear from Shema and get the next aliquot.
Okay, the discussion was on fire again, and I love this negative. So, her urine biochemistry revealed a specific gravity of 1.004. Her urine osmolality was 175. The urine pH was 7, and the urine anion gap was 23. The potassium to creatinine ratio was 3.9. We did some repeated urine studies that showed a persistent alkaline urine, so the pH was within 6.5 to 7. There was no sign of glucosuria or phosphaturia. And we did a urine sediment that was notable for sterile pyuria and also for the presence of eosinophils. And then besides the urine studies, I give you some other labs before I will move to the last aliquot. So she had a mild polyclonal gammopathy with predominance of IgG and undetectable IgG4. And I will stop here.
Hey, Robbie, go ahead and tackle this, because I just spoke for a while, my friend.
Oh, Prof. Rez, I think I would love to hear how you think about this, in large part because I think you're just so good at teaching us nephrology. I'll share some advice, though, just management-wise, because I think that comes up. And I think there's a couple of management pitfalls here. The first is I didn't realize, Prof. Rez, the concomitant respiratory alkalosis. And the truth is, when you pointed out, I worried a little bit, because I'm trying in these VMRs to like practice what I would do in real life just for my own growth. And it made me realize one important management pearl is when somebody is this weak, you have to make sure to think about their respiratory status. So could she have such profound hypokalemia that she has diaphragmatic weakness? And is the respiratory alkalosis that she has an attempt to hyperventilate and to compensate for diaphragmatic involvement? So that's one thing that should cross your mind in all these patients, and certainly after you see respiratory alkalosis. And here's the management tip. in this patient, you should do neck strength testing. That correlates well with diaphragmatic strength. So of course, that's not a diagnostic move and not something we discuss in VMR, but probably a good thing to do is to see what her neck flexion and extension are like, and to make inferences about the state of her diaphragm from that move. And then the other thing this case shows you is if you were taking care of this patient in the emergency room or anywhere with access to acute care, you would see that she's frail, that she's weak, and you would probably be inclined to give her a liter or two of normal saline before you got the labs. That's a mistake. And you can see why, because you'll make her non-gap acidosis even worse with normal saline. So this is another example of how being cautious with fluid management is really important. If somebody's not tachycardic or hypotensive, if giving them normal saline can either rapidly correct their hyponatremia, which you don't know about, or you can worsen non-gap acidosis. And so you have to be careful, a little bit more careful than I think we tend to be with fluids, especially NS. So 2 pieces of advice from a management perspective. I definitely assess her neck strength. I'd be cautious about normal saline in people who don't overtly need it, because you can cause some electrolyte issues. It's not harmless. And then finally, one thing that'll come up for people who are just transitioning to more senior roles is how do you replace the potassium? And potassium repletion is a function of kidney, is related to kidney function. So most of us, our goal would be to try to get to the potassium to around 4. This patient's GFR is 42, and I bet her actual kidney function is even less good because of how much cachexia she has. So I would say that her GFR is probably maybe 30, and as a result, I would probably half as much potassium as I would normally give her. So ordinarily, in order to get somebody from 2.5 to 4, you'd probably need 150 milliequivalents. But owing to her probably advanced kidney dysfunction, I would probably only give her 60 or 70, recheck and replete. So there's a lot of subtle stuff with management. Check muscle strength. Don't go bananas with normal saline. It can cause some problems. And give bananas to patients with potassium, but be careful when their GFR is low. But Prof. Rez,
Robbie, can I just add, because I'm loving this management discussion. I think it's so helpful for all of us, not just young learners. How are you giving like the potassium? And I don't think there's a right answer here, but can you tell us the formulation? Like how much of it is IV, how much of it is PO?
Yeah, Prof. Rez, I'd love your input on this too, because I think the more opinions people have, the better, because I don't think there's a right way to do it. The downsides of oral is that the pill is very large, caustic, and sometimes associated with esophagitis, and also hard to swallow. The IV formulation is a little bit slower and burns, but is reliable. If you give it, it goes through, you've given it. So often I start in this patient, I would probably give her 40 PO and 40 IV to balance the side effects of each of forms. What do you think you would do?
That's exactly, I think, what I would do as well. I was just curious.
Yeah.
Because there's never any like strong data as to like how we should do this stuff. But but thank you for bringing up the management aspects of this case. And I absolutely love these labs. Because Austin helped me explain one of the lab abnormalities, which I forgot the mechanism for, but we'll explain each of these. So first of all, the urine anion gap, we know it's P-zative. So if it's P-zative, it's renal wasting, which was our expectation, right, to begin with. So that explains that. The eosinophilias is not surprising because if you look at our nephron and interstitial nephritis, we know Sjogrens is a common cause of interstitial nephritis. So probably it's causing interstitial nephritis. The lack of glycosuria and phosphaturia, to Austin's initial point, that we're not dealing with the proximal RTA, which could cause a normal gap metabolic acidosis initially, but that usually causes a negative urine anion gap early on in its phase. Then the high potassium to creatinine ratio is just saying that this is a very important pearl. Whenever you want to know, is the kidney the cause of the abnormality? Just ask the question, what should the kidney be doing with the systemic abnormality? So for example, if someone is hypokalemic, right, systemically has low potassium, that kidney should be hanging on to every last ion of potassium. But the fact that it's not tells us that the pathology is at the level of the kidney, right? So that tells us that you're just wasting potassium. Now let's do the same exercise with the urine pH. So the urine pH is high, so it's alkalemic. If the patient is acidemic, what do you expect that kidney to do? You expect it to dump out acid and to reabsorb bicarb. The fact that it's not doing that again tells us that the metabolic disturbance is at the level of the kidney. And then finally, the urine specific gravity, it's teetering towards diabetes insipidus. And you ask the question, what causes that? We have a schema, all of this is in our schemas of nephrogenic DI and hypokalemia being a cause of nephrogenic DI. So basically, this just confirms Shema, our hypothesis, that this patient's losing potassium through the kidneys, that the patient has an RTA, and that most likely with the poor dentition, the dry mouth, it's Sjogrens. And so we anticipate that the next series of aliquot is antibody testing of SSA and and SSB. Is it SSA and SSB? Is that what it is, Robbie? Or do I have?
Yeah, I think so. They have other names like ROLA, but
ROLA, right?
Yeah. SSA and SSB will be my Sjogren's antibody A and Sjogren's antibody B.
Any other pros, Robbie, about the serology in Sjogren's, like how often it's absent or?
Oh, I don't know it well enough to know how often it's absent and stuff like that. I just know that I remember a case that Aaron sent to me because I was asking him about Neuro Sjogrens, and there's a measurable rate of negative. He sent me a case where it was Sjogren's, but the antibodies were negative. So I just know that, but I don't know how often that happened. I think the thing that I should have thought about earlier that didn't was the IgG4. It's a very good mimicker of Sjogren's, and the fact that the IgG4 levels are undetectable makes that much less likely. So completely locked into SSA, SSB like Prof. Red.
Okay, superb. So now I will give you some of the final labs. So we did some antibody testing, and so the ANAs were 1 to 1,280. Her SSA, and SSB antibodies were very high. And there were no antibodies against salivary protein 1 or parotid specific proteins. Antibodies against carbonic anhydrase type 6 were negative as well. And we also did a kidney biopsy. And in the kidney biopsy in PAS staining, it was showing tubular atrophy, interstitial fibrosis, and inflammatory infiltrate in the glomeruli. And the HE staining was showing eosinophil infiltrate in the interstitium, tubular atrophy, and intact glomeruli. And let me check whether I have something else. Yeah, I would stop here and let you discuss.
So I think this is a pretty good case of sarcoidosis. I'm just kidding. I'm kidding. All I will say is, Deborah, I don't see your video. You're probably doing something else. But I thought of you so much when we saw PAS stain. Prof. Rez, Deborah and I co-discussed a case that Jas presented yesterday that made us panic a little bit about what PAS means. I still don't know what it really is. Prof. Rez, do you know what PAS staining is? Do you know more about it?
I just know it's like periodic acid shift staining, and basically at the laboratory level, I'm just joking.
Anyway, that's my only contribution. Yeah, I think just to shed some light on how Sjogren's is diagnosed. So you need 4 out of 6 criteria. I don't know how often each is negative, but the 6 total, you need 4 out of 6. The 4 are very intuitive. You need dry eyes, dry mouth, and then you need to prove biologically that there is dry eyes and dry mouth by doing the Sjogrens test. You put a piece of looks like a piece of paper, honestly, and it tracks how much the tear film makes it as far down. I'm probably it's called the Sjogrens test, but I don't know what they actually use. And they do the same thing for saliva. So that's 4 right away: dry eyes, dry mouth, and then objective proof of dry eyes and dry mouth. And then the latter 2 are antibodies, which count as 1, SSA or SSB. And then the final one is a biopsy showing lymphocytic infiltration. Usually you can actually biopsy even the the lips because you have minor salivary glands in the lips. So you can do a simple lip biopsy to do it. And I think here, dry eyes, dry mouth, serology gets you 3 out of 6. And so the question is, do you do objective Sjogren's testing, or do you do a biopsy, or do you say, wait, the renal biopsy is good enough, we don't need to biopsy the salivary, and the renal findings, the RTA, so on, is so suggestive that we'll just call it that. Yeah, those are my thoughts. What do you think, Prof. Rez?
I love it. Nothing to add.
Okay, so very good discussion. So as you already mentioned, she was diagnosed with Sjogren's disease and distal renal tubular acidosis, and also she had a tubular interstitial nephritis. Yeah, so yeah, that's the solution of the case. And I will also tell something about the management. She received an aggressive therapy with potassium chloride, sodium bicarb, and amiloride. And she was also treated with immune modulatory therapy, including hydroxychloroquine, azathioprine, and a taper of prednisone. And yeah, and I want to thank you so much for this amazing discussion. I know my ring is belling. Do you say bell? Yeah, that's why I was a bit. Yeah, thank you so much.
Oh, Shema, you're the absolute best. Thank you for pulling up this case and for presenting it so clearly and for teaching us so much. I'm really curious, Shema, what do you think you learned when you read the case the first time? What was the major learning point for you when you were going through this journey by yourself?
Actually, the point with this renal tubular acidosis, I mean, I was so fascinated by the case that Amanda presented. And when you mentioned this the first time with this urine anion gap, so there was like my major teaching point, as you mentioned. And I have to say, I'm still struggling a lot with all these metabolic disorders, and that's why I wanted especially you guys to discuss it, because there's always a learning point. And now also to read, I didn't know that hypokalemia can cause nephrogenic DI. That was also now such a big learning point for me. So thank you so much.
It's always a pleasure. Always a pleasure. All right. Well, to the PAS stain champion, Jas, you want to take us home with your teaching, my friend?
Definitely not the champion in that. Can you all hear me? Great. I kind of felt like an amateur play-by-play trying to dictate what Mbappe and Messi were going back and forth on. So let's see if I captured enough. So great discussion by both. So Robbie started us off by saying, basically, try not to assume that the weakness is MSK in nature. Initially, they may have myalgias or non-MSK related form of weakness. And the initial chief complaint may actually signify a pain syndrome. And the next question to ask is she actually neurologically weak, which will probably come from further HPI or physical exam. You also want to need to verify and categorize the weight loss, which Reza reminded us, it really matters about how much, tempo, and intent, whether this was intentional weight loss. And then Reza further went on about low potassium can affect both muscles, heart, and the GI tract. It's important to see how the low potassium was in the prior ED visits, because that would also matter as well. And then obviously quick schema on the low potassium. Was there any decreased oral intake? Was there any increased GI losses? Was there an RTA involved, so AKA renal loss? Or was there a cellular shift? And then in terms of Sika syndrome, so dry eyes, dry mouth, very common finding, not always related to Sjogren's. You would need to see if there are other visceral involvement, like the thyroid, liver, neuro, or like Robbie mentioned at the end, that there's like you need 4 criteria to actually diagnose with Sjogren's syndrome. Poor dentition is something that you should probably pay more close attention to, rather than just a dry mouth, as lack of enzymes in the saliva that typically protect the teeth can lead to erosion and lead to poor dentition. Proximal, and then one of my favorite pros, proximal muscle weakness plus reflex impairment is more consistent with a peripheral etiology versus central, and this should make you consider a neuromuscular junction issue such as myasthenia gravis and Lambert-Eaton syndrome. If you see on your ABG with a low pH and a high POCO2, this makes metabolic acidosis as one of the primary disorders. Normal gap acidosis, you got to confirm with Winter's formula. And then the next step should be a urine anion gap. And if it is negative, this points towards GI losses. Then the patient does not have, if this patient that Shema presented did not have any evidence of decreased oral intake, GI losses, or a cellular shift. So that's when Reza focused in on to the kidneys and was wondering if this is a renal insufficiency or CKD or some type of injury. But in that case, though, potassium should be high, not low. And then that's when we started talking about possible RTA, and patients with Sjogrens syndrome also have antibodies against the salivary glands, but those same antibodies have tropism towards the distal tubules of the kidneys, leading to that distal RTA. Some management pearls were shared. So when someone is this weak, you got to have to worry about the diaphragmatic involvement and respiratory distress. Make sure you assess the respiratory status. The other pearl was avoid normal saline administration in an individual who has metabolic acidosis, because you can worsen it. And then given her kidney function, even though this patient probably could have gotten over 150 milliequivalents of potassium, you want to replete it conservatively. You want to probably start off with 40 IV milliequivalents of potassium, followed by 40 milliequivalents of PO. So in this case, what should so when we're looking at the urine anion gap, what should the potassium what should the kidney be doing in a low serum potassium? The kidney should be reabsorbing all of the potassium ions. So when you see a high potassium to creatinine ratio, this suggests renal wasting, because there should be low potassiums in the urine. So this makes RTA very likely. And some other side pros that were thrown in the chat and also by the discussants, that low hypokalemia can also lead to interstitial nephritis and diabetes insipidus. Lastly, you need 4 criteria for Sjogren's syndrome, Sicca syndrome, so dry eyes, dry mouth, and just a side pro, for some females, it can actually have vaginal dryness as well. Need to have Schirmer test positive, antibodies positive, and lastly, a tissue biopsy, either of the lip or salivary gland, that also confirms that diagnosis.
First of all, that was like superb. And something interesting, Jazz, look straight ahead. There's like, oh yeah, just like that. Like right above you, it looks like you're an angel just teaching us, or like this white ring of light. And really your teaching was angelic. Not to make this a religious VMR. Robbie, any thoughts?
No, it was absolutely superb. Absolutely superb. Thank you so much, Jazz. I really, really appreciate it. And yeah, it's such a treat to hang out with all of you here today and to go through this case and learn and laugh and laugh and laugh. So hope you have a fantastic weekend, and yeah, see you next time.